Hello, everybody. Can everybody hear? I never like being tied to a pulpit, but it helps with the microphone. It's nice to see everybody back in person. It's been a while since I've done any presentations. This is my first one in person in a while, so you'll have to excuse me for any stumbles here. But it's nice to see everybody again. This is similar to a presentation that I've done through the Rhode Island Geriatric Education Center. And the meaning behind strength-based model of care is really focusing, trying to change our mindset as to what we think about when we see someone with dementia or a person with dementia. You know, what are different ways that we can view this individual as a person and not just a list of diagnoses. So there's no good presentation without strong learning objectives. So here they are. So we're going to define strength-based model of care. We'll start that right off the bat. We're going to summarize how to do a strength-based interview. Sometimes I think models are very well and nice, but if you can't apply them, well, you know, it just sounds good on paper. So we're actually going to apply what we learn here, and we're going to look at different strategies to help maintain strength-based strength model of care and resilience. So I know there was a presentation earlier that went over a lot of this. So, and I know you know, we're all working in the field, so I'll just go quickly. But dementia is a progressive decline of cognitive function. And not all dementia is Alzheimer's disease. Alzheimer's disease is a type of dementia, really meaning to that there are many different types of dementia, right? Alzheimer's disease is the primary one. It's the one you hear most about. It is the most common, you know, approximately 60 to 65% of all cases. A lot of research now, too, is having difficulty identifying exactly what type of dementia people have. The only definitive way to do a test to see which type of dementia somebody has is to do an autopsy on the brain after they've died. So it's hard to get percentages, but they're finding a lot of people have mixed dementias, that it's a combination of one or two of these. So Alzheimer's disease, classic plaques and tangles in the brain, slow progression over time. Vascular dementia caused by strokes can be a little bit more stepwise in function, not always necessarily. Lewy body dementia, caused by these Lewy bodies in the brain. There's a lot of fascinating research saying that it might be strongly connected with Parkinson's disease. It just presents in a different way. So that's about 5 to 15% of all cases. And frontal temporal dementia. So again, I don't think this is new to anybody, so we'll keep moving on. But I do want to say that depression so often goes with dementia, and I think that's something that is typically overlooked, is that depression symptoms are reported in about 40 to 50% of cases and can actually worsen outcomes in dementia. So if you think if somebody has to take a test and they're feeling more depressed, they're not going to do as well on this test. Similarly, if somebody has dementia, they're not going to do as well on this test, and the brain is just not functioning well when a person is feeling depressed. You're having that cognitive slowing. And when you see that, that will actually accelerate the disease itself. You'll see an increase in symptoms. So it's important to address not just the physiological, biomedical model of dementia, but also, you know, someone as an individual and how they process life and how they view the world around them. What brings them their satisfaction? Right? Like, what goals do they have? What is it that they would like to do? So we want to address the chronic illness, right? It's hard to treat. There are things you can do to help with the disease, but there are no cures. So we want to look at what are each individual's changes? What are their cognitive changes? What are their physical changes? Do they have chronic pain? Do they have other physical illnesses? And who do they have around them? Do they have caregivers around them? Do they have family around them? Do they have the financial resources to, you know, pay people to stay in their home? So each situation calls for unique solutions, right? So long story short, everybody is their own person. And while we can meet them through their disease and kind of have general ideas as to what we want to do, each person requires a unique approach. Okay, so I promised we would start with strength-based therapy. So the textbook definition is that it is a client-direct approach that invites people to participate in every aspect of care and to apply their indigenous strengths and resources towards personally meaningful goals. So we want to focus on the person, figure out what are their strengths, what do they naturally have for strengths, and what are their goals. So similar to other models, we want to put the client or the patient first, right? So often I think in healthcare we can come across as the expert, right? People turn to us, and it's very easy to get to our pulpit and proclaim ourselves as experts, and we can tell you this is what you need to do. But it's important to put the patient first, and we'll see that in our interview in a little bit. So just a brief history. It's from a lot of different sources. The father of this theory and model is Donald Clifton. He's the one who set the theoretical framework, the general idea to focus on somebody's strengths, not somebody's losses, right? Like, it's so easy in healthcare. We have it right on the front of our sheets is a problem list, right? And that's helpful information to know what problems somebody has. You know, you want to know if they have heart failure, you want to know if they have diabetes, but sometimes when that happens, you can really pigeonhole somebody into what you think they look like, right? We don't have any lists on the opposite side that says, this is what they like to do. These are their goals, these are their activities, explains more of them as a person. They just come as a list of problems. So he wanted to turn that on its head, which of course a lot of people jumped onto, and including social work and counseling, nursing. There's been a lot of research that's all come together recently on this, or even just over the decades. So the primary assumption that we have is that we are heroes in our own lives, in a sense. We are in control of our lives. This isn't a mindset where we are going to innately suffer. We've been dealt a hand, we've been dealt a diagnosis, and what we want to do is address it as best we can. So we must accept the call for adventure. My wife is an English teacher, so that is the step of the hero's journey, right? We must accept the call or decide to step back and fall victim to ourselves and not have an adventure, not have a story. So we must accept this. And in doing so, in creating a story, we have to find out what are our strengths. What can we do in this story? So, general definition of a strength is that which helps a person cope with life, makes it more fulfilling to themselves or others. So, primary goal, we want to focus on what's working versus what's not working, right? A problem list is a list of, these are the body systems that are not working. We want to create a list of, these are things that are working. We want to accentuate what they have rather than what they lack. It's very easy for, as a patient, I don't know if you've ever felt there's a myriad of things that you can't do, right? Like if somebody has a stroke, all the person can think about is what they are no longer able to do, and they can't even get into thinking of how they're going to do it again. So we want to focus on what they can do and emphasize the strength within the struggle. And I'll bring that up a couple times again. We want to emphasize the strength within the struggle. So we're not going to say, don't worry, you just need to focus on your strengths and everything will be okay, right? I think that's where sometimes models look good on paper, but that's not the assumption. We're saying this is a difficult diagnosis, this is not easy, but you do have some strengths and you are able to address them. I love the opening line of David Copperfield, whether I shall turn out to be the hero of my own life or that station be held by anyone else, these pages must show. So I'm not going to read all of these. I think the handouts, you have the handouts or are able to get the handouts. Some of the slides can be a little word heavy. But essentially we're going to focus on the person's strengths, not their deficits, right? Counseling, for example, if we look at the second one, is possibility focused, not problem focused. So if it's problem focused, we're trying to address something specifically as opposed to possibility. What can we do? Okay, we have a diagnosis of dementia. What can we do? What are the possibilities that we can do? It's a collaborative process. Again, we're not just the expert. I think it's very easy to fall into that role when people ask us questions and we have this knowledge base and are able to help people, and it's very easy to help them rather than helping them come up with their own solutions. And that's where the individual and the family are valued, as opposed to just telling them what to do. Or you're not really paying attention as to who they have around them. You just tell them what to do and expect everything will get better. So the core concepts. Generally, the 3 core concepts, we're going to focus on what remains versus what is lost. And we'll see this a little bit in the interview. We're going to build support, build a sense of purpose. We want to find out what their goals are. And a lot of times if you ask somebody like, I would like to know what you want, people have no idea. People have no idea what their goal is. And it's very hard to work with that. So we're going to come up with ways to make it easier to talk with somebody to help make a goal, including just the quality of life and their emotions. And the third one is to try and change the internal dialogue within themselves, right? Like it's very easy for healthcare providers, for patients to think of what they can't do as opposed to what they can. And ultimately, what is going to give meaning to their lives, despite this diagnosis, despite the hand that they've been dealt. So if we think of different types of strengths, I've mentioned some of them, but here's a slightly more inclusive list, but certainly not all inclusive. Things like living arrangements. Does the person own their own house versus do they rent? Do they live with anyone? What are their social relationships? Do they have any children that they live with? Do they, have they moved from New York and don't really know anybody here? What are their assets? How much are their finances? Do they own their own house versus renting again? What are their typical health routines? What do they like to do to help pass the time? Do they like to exercise? Do they like to garden? What kind of specialized knowledge do people have? This is always my favorite thing to ask, like what people did for their lives, because you'll get a variety of different answers. One of my favorite patients I still think about all the time was a lumberjack. This is big, like 6'5", 250, just like all muscle guy. Despite his old age, was still very strong. So I asked him, I said, what did you do in your life? And he said I was a lumberjack. It's like, that's just something out of like folklores, in my mind. So I was like, wow. Where do you do a thing like that? You probably not Cranston, probably not Warwick. Do you drive to like Exeter? Do you go all the way down to Exeter? And he lived in the Pacific Northwest. So I said, wow, I've never been west of the Mississippi. Tell me about what it's like in the Pacific Northwest. And he said, well, it rained a lot. And I said, well, I've heard that. But to just talk about their specialized knowledge, he might not have been able to keep up with the more recent news events. But he's able to talk about his life and really talk about his own special expertise, where he was telling me about trees and the types that are good for lumber versus the ones that aren't. And it was just really, really interesting. Similarly, leisure, what do people like to do? Are people musicians? It's something that can be a hobby for a lot of people. It's really interesting whenever it's a profession that they've really made it through, but is that something that, they get pleasure out of, that they get enjoyment out of? That doesn't necessarily come up. And additionally, culture. It's important to remember, different people's cultures and to just be sensitive of that in general. And I think it's important to just ask, open-ended questions, non-assumption questions. But we'll get to that in a little bit as well. Okay, so this is the long-awaited case study. So when talking with persons with dementia, I found there's a couple different strategies that are helpful versus some that are not so helpful. The first one is not being goal-oriented. This can be so hard, right? We only have a certain amount of time, whether it's inpatient, outpatient, whether it's home care visits. You kind of have on your paperwork a list of questions you have to ask to, get through the billing process, to make sure that you've coded everything correctly, whatever it might be. So you have these list of questions, and it's so easy to just run down like number 1, number 2. But it's a lot easier to just get the answers by talking with somebody, getting through a conversation and not just getting through a list. And I think that's a skill that people are starting to lose, especially in interviews, just in general, because we have so many lists to go off of. So don't start with the disease, start with the person. Avoiding assumptions is always good. You don't want to say like, it looks like you have a good relationship with your daughter. Because the person could be like, are you kidding me? Have you seen my daughter? She tells me what to do all the time. And you kind of know it's like, well, she's trying to do the right thing and trying to make sure that she stays safe. And, so saying like, do you have a close relationship with your daughter is kind of leading, right? Even though could be deemed close. You want to tell me about your relationship with your daughter. Tell me about your daughter. You'll get more information that way. Again, you want to acknowledge the struggle. You don't want to come off as overly positive, to be like, oh, don't worry, I've done this 1,000 times, there's nothing to be worried about. It's not really the best approach. You want to say, I have seen this before. I've seen that it is challenging. I've seen a lot of people overcome this challenge, and I want to help you do that as well. So kind of guiding them, like what gets in your way? Again, available community resources, which is lovely to see here. I don't need to go over it in any more detail, I don't think. You can just go out to the vendors and see. What I've really enjoyed since I've kind of changed my own practice is not necessarily focusing on education, right? Again, it's so easy when somebody asks you a question, like, what would you do here? It's so easy to just give them information. Or like, why does my mom have dementia? It's so easy to say, well, let's go through this old PowerPoint. We have 65% of the time it's through Alzheimer's disease, this is through plaques and tangles, but maybe it's through strokes, maybe it's through this variant of Parkinson's disease. You're not really giving much information. Well, you're giving them information, but you're not explaining what they're trying to hear. So if they say, like, why does my mom have dementia? I think it's better to come up with a question to be like, is there something that's worrying you about it? Do you think that something might have caused it? Because a lot of times these questions have kind of their own information behind them, and it's important to get that information rather than just jumping on education. Not that that's not important, but I think it's important to get the information behind it first. Again, you want to see how do they focus with memory loss. You don't want to use big fancy medical terms. Behaviors are, termed differently for each person. And again, remember that a person has abilities throughout every stage of dementia. Okay, so let's talk about Mary. I know everybody can read here very well, I'm sure, but I will get through. She is a 78-year-old white, non-Hispanic, widowed female, recently hospitalized for COPD, generalized weakness. You're part of her home care team. Okay, so we're going to her home to assess her. She has atherosclerosis, peripheral artery disease, neuropathy, COPD, no past surgical history. So again, there's our problem list. Here's our medications. Upon reviewing the chart, you see 3 months ago, the patient had an annual wellness visit with her PCP. At that time, she was diagnosed with mild cognitive impairment during a routine screening, right? It's common nowadays. Generally, after 75, you want to have some even baseline cognitive screening. Social history, just a little bit. So she was born and raised in Providence. Her father worked in the jewelry industry. Mother was a homemaker, one of 5. Graduated high school, worked as a secretary for the Warwick School Department. Married at 22, married for 51 years until her husband died of cancer. She has 2 sons, 1 daughter who live in Rhode Island. She currently lives independently in her own house in Warwick, able to manage her groceries and bills, but has some difficulty cooking. Hobbies are gardening, reading mystery novels, watching Hallmark movies, especially around Christmas time, and occasionally socializing with her church. Okay, so you walk in, you say hello, nice to meet you, you put your stuff down. She starts up. My doctor said that I have dementia and there's no treatment or medication for it. She just told me to eat well and exercise. I think we laugh because this is based on a true story. So you want to reply, like, it sounds like she didn't see your worry, right? That's what's in that sentence, is that she's worried, right? There's no treatment, there's no medication. I just have to eat well and exercise? I've known that for 50 years. So likely this is not the best time to provide education, right? She's already frustrated about her previous education from her primary care. So you want to think, where is this coming from, right? You're here for her COPD exacerbation. You're here as a part of her home care team. You're just meeting her, and she's bringing this up. So what is it? She's not being heard. So it sounds like she didn't see her worry. Right, I have neuropathy and COPD. I struggle to get around the supermarket, get around my house. Right, how is she gonna exercise? She can't even view. She's thinking exercise could be like a marathon. I don't know what to do. What is this exercise, right? When you see the Boston Marathon, is that exercising? Do I have to start to do that? And again, what is the purpose behind exercising? A lot of people get enjoyment out of exercising. It's not just a labor that we do to try and live longer. What is the enjoyment that we can get? So instead of education, right, why don't we just ask, tell me, what are you able to do around the house? What's your general routine? If you can't get around the supermarket, what can you do? So this is a good bridging statement to try and get to some strengths, right? Okay, the supermarket, difficult. What can you do? So you don't want to assume. Tell me about your daily routine. You find out she drives, buys groceries, goes to church. It sounds like you stay active even when it's not easy. So you're acknowledging this struggle, even when it's not easy. I say this for everybody when I ask what they do, right? It's hard. The reason we all get paid for our jobs is because it's hard work, and everybody can acknowledge the struggle with that it's difficult. So it sounds like it's not always easy, but you're able to do it. So what motivates you on these hard days? So she says, I've always lived on my own. Even after my husband died 5 years ago, I don't want to burden my children. This is my home. Okay, so let's start to take this social conversation that we're having and kind of bridge it into a more constructive working relationship conversation. So here is important things. She told you a couple of her goals. She sees herself continuing to live in her house. She's lived here for 40 years. She's going to die in this house. I don't want to go to a nursing home. I don't want to burden my children. So these are her goals. And again, when you see them, don't necessarily jump on them immediately, similarly to education, but just have it in the back of your mind, right? When you're taking notes on a conversation, don't just take word-for-word notes. Think of these goals. Like, okay, her goal to stay in our house. So let's talk about that. So now we know what her living arrangement is like. What is her relationship strengths? So who is in your family? You don't want to burden your family. Who is in your family? So she has 2 sons, one daughter, 5 grandchildren. How is your relationship with them? Again, you don't want to assume. So how is the relationship? My children, you don't want to say how close you are with the children because sometimes they'll think geographically. So it's like, how close are you with your children? Oh, they live down the road. They might never see them. My children all live nearby. I speak with them weekly. They bring their grandchildren to visit. All good things. So she enjoys seeing them. She enjoys going to church. Who else is supportive? Described her church. So that's good. So these are her relationship strengths. So could this be a future goal? If she likes to do this, talking about activities, is this a way that she can get more activities? Okay, so now let's start to link just a couple of these strengths to outcomes. So you mentioned your husband passed away earlier. That must have been incredibly stressful. What did you do to help manage your anxiety? They had a garden that they tended together, and she kept it going. Okay, these are some leisure activities, some leisure goals. It sounds like you're worried about keeping up that garden. What do you think will get in your way? She's worried that she can't even take care of herself right now, let alone her garden. What worries do we have taking care of ourselves? Right? Definition, what is her garden? You know, my definition of a garden is I have like one tomato plant and a potted plant, and that's my garden for the summer. Some people have a nice compost pile. They have nice beds that they rotate the soil and, you know, do a great job. Is that her goal that she wants to do? You know, what does the future of gardening hold for her? So again, what makes this different from a social visit, right? Like it's interesting. I enjoy talking with people. People always have very interesting lives, but we want to have a working relationship with them. So we're going to address the struggles and the strengths. So at the end of the conversation, you might say, I hear that you're proud to be living in your own home and spending time with your family in church. You want to acknowledge that you've heard them. And what do you fear will change from this? After learning more about you, let's come up with some goals together to still find ways that you do what you enjoy. So you don't need to do anything quite this formal, but this is just an example. So again, we'll just run through a couple of them. So she wants to remain living independently in her own home. That's her current strength. She is able to currently live there. Her goal is that she will hope to continue to live there. So what are her strengths to achieve that goal? Well, her strength is that she's able to manage a household throughout her life. So she's been able to do it before. To help her do it, she also has these supportive relationships. She's currently close with her family in church, so her goal is to remain close and to see her grandchildren. And she's been able to do this before. So how are we able to continue these things? These are the goals that you want to do. Again, just in terms of her health and wellness, she's able to walk with no history of falls, which is great. So we want to continue to have her walk well throughout her house. You want to have her start a garden. That has been a past success. She had stopped smoking before in the past, but still has that lingering COPD. You want to help bridge this to goals, is kind of the long and short of it. It's very easy to just kind of talk with somebody, but what is it that they want to view for their own life? So again, it's one of the things I always think models, kind of like math. Like it makes sense. It sounds well on paper. You can kind of do it when it's in front of you, but it's hard in front of you when you're trying to add it to your practice. So here's a couple ways that you might be concerns, tips and tricks to add it. So again, you don't want to focus just on the strengths. You don't want to disregard the person's fears and concerns, right? They're really worried. The first thing she said to you is, I don't know what to do. So you want to acknowledge that, and not just say, oh, let's just focus on what you can do, because then you're really dismissing, their own worries. It's so easy to walk into like yeah, but, and again, that comes from the expert mindset that we have, right? Like even when somebody is talking to you, can't you tell when somebody has a but coming, that it's just they're talking and you're just waiting for it. Oh, what don't they like? They don't like something. So instead of saying yeah, but, and then talking about something else, kind of dismissing them, you want to say yes, I'm hearing you, and let's do this. Rather than yes, but, because it's dividing. Just the context of the language itself. The and is adding it on. I'm hearing what you're saying, it's a hard struggle, and this is what we're going to do about it. Rather than I'm hearing you, this is a hard struggle, but we can get through it. It's just a little different there, but it makes a big difference. And that and allows you to transition to their strengths. So difficulty finding strengths, right? This can be very difficult in someone who's hopeless, right? Who's not feeling well, whatever it might be. So the therapy does not assume that they are naturally able to solve their own problems, right? So we want to work with them together to try and come up with solutions as best we can. So good sentences, good questions can be like, when were you last feeling good? And I love this question because you could get kind of the joke answer of like back when they were 30. That was the last time I had ever felt good or felt like I had strength again. I don't know why. I had a patient recently tell me when she was 29, that was the best she ever felt. And she was like, why? Can you tell me why? So it's interesting what you might get as opposed to when did you last feel good? I felt good around Christmas. Okay. What did life look like around Christmas? What were those, why was that good? Why were things going good? And then talking about difficult times that they have had before. It seems like you've always been a fighter. It seems like you've had to fight through challenges before. What's been your success? How have you been able to do this before when, life has given you a hard hand? How have you handled change, just change in general in the past? A good one, if somebody is feeling very hopeless, is how do you explain your previous success? How do you explain you did so well, and despite you not wanting to exercise, you ran a half marathon, whatever the example might be. Because I think people kind of subconsciously have an idea as to why they did well before, things have changed, and they're not going to get better. So it's important to get to that. Why were things going well before? So giving someone hope, that's really the fuel for action. If they have hope that they can be a hero in their lives, that they have choices that they can make to have them feel better, they will be more successful. And just in general, what do you hope to get from the sessions, right? So you're the visiting nurse here for the COPD exacerbation. Okay, what do you hope I can do for you, in the brief time that we're here? Whether it's one session, whether it's the week's sessions, whatever it might be. And again, you want to link it to an outcome. So the strengths is not just the end, right? If someone's a musician, be like, wow, that's, it's quite an accomplishment to be able to play the piano. Okay, I'm moving on to my next question now. You want to, wow, you were able to play the piano? Tell me about that. Find strengths in their goals. What do they like to do? Is it something that they want to get back to? Is music something that they've really enjoyed? So rather than a client-oriented, where the person's telling you, where you're talking to the person, it's client-directed. So really, they are the ones that are in control. Because as much as, even for home care visits, where you have a 2-hour session with the person, that's a long time to be with somebody in their home and work with them, but it's also not, right? Like they are on their own for the other 166 hours that are left in the week until you come back and see them again. So it's important for them to have their own direction. So if they're difficult to engage, first, am I just talking too much? Then remember, some people are just less talkative than others. Might not mean that they're unmotivated. Open-ended questions, right? These are always the way to go. It's almost a cliche, I think. So I like to talk about how they're not all equal. So we have open-ended questions. If we have the first one, like, how's your appetite? You get the answer, good. I guess according to textbooks, that is an open-ended question, but you didn't get any information. As opposed to like, okay, let me try again. That was your 8 o'clock visit. Now you're going to go to your 10 o'clock visit and say, okay, let's have a different approach. What did you have for supper last night? Chicken and potatoes. Okay, it's better. You at least kind of know they're having a protein, they're having a starch, but it just kind of ends there. How much? How much was it? Did they want it? Was it prepared? Were they able to feed themselves? So let's talk about the most open-ended question. Tell me how you prepare your meals. Are you able to prepare your meals? Who helps you prepare your meals? What do you like to prepare? It opens up the conversation a lot more than some other of these open-ended questions. So try and think about questions that are like, tell me. And you can still promote change talk without a long discussion. If the person is overly talkative, I find this more than the opposite. Starting the conversation like up front, like a preventative strike. I only have so many minutes to talk today. What is important that we address? Essentially, you're just cutting to the chase, because it's like, okay, I'm here for your COPD exacerbation from the hospital. What do you want to talk about? I only have 20 minutes. So what are the problems you're having? Or what would you like to talk about first? Setting the stage, kind of bridging that to that statement. Like, I would love to hear about your grandchildren's artwork. I just wish I had more time to hear about it. I only have 10 minutes, and I have another patient who's just as important as you. So let's focus on what you'd like to talk about. Kind of that bridging statement. Acknowledging them, but getting to the next point. And just in general, kind of anything in life, you want to be patient with yourself, be persistent, give yourself some time. It takes a while to come up with things. I still say things all the time that I was like, I shouldn't have asked that. Like, are you, talk about being close with your family, and they tell you they live down the road. And I was like, I would never think geologically close. So it's important to just practice. Work on exploring with your patients. I should have said this up front too. This is certainly not an expert speaking from a pulpit as this is the correct way to do it and everybody else who does it is wrong. This is just a way to approach patients that can be somewhat difficult to interview. If they have dementia, there can be that depression. There can be that hopelessness. There can be the memory loss on top of, being able to answer these questions. They might not be able to answer them. So always enlist help from others for a multidisciplinary approach when necessary as well. Okay, so I have a little bit more time, so let's go back. Okay, sorry, I lost my place. So let's go back to our tips. Let's not be goal-oriented. So if the person is a poor historian, you're going to run through your list of questions, and all of the information is going to be wrong. So you don't necessarily want to do that. Allow being guided in the discussion. What is it that they want to talk about? But also keeping in mind you want to have certain goals. So picking up where we left off. This is sometime later. I think I put it 3 years later, but I didn't make it clear here. So the patient is less social and content to have the daughter answer the questions. She's there now for the home visit. She had an episode of confusion and disorientation about 6 months ago. She was hospitalized and treated for the dreaded UTI. She appeared to do better after antibiotics, but her family has noticed she no longer cooks and was making errors in her finances. Family now stops by multiple times a week to check on her. How many people see this, where there's kind of one incident, right, that happens, and all of a sudden this chronic, slow, progressive illness happened all at once? I think when people go to the hospitals, a UTI can cause confusion, but a lot of times there isn't necessarily an explanation as to why a person might be confused. Let's say they woke up in the middle of the night, fell, they go to the hospital, if they're confused, what could it be? They check their urine, they have, asymptomatic bacteria. So that means that it was the UTI, and they treat the UTI, but it kind of brings everybody together and they kind of pin it on the UTI rather than just the dementia process. That's kind of a lecture for another day, I guess. But it's important to not just recognize when these things happen. Okay, so you hear about her decline in cognition. So the daughter's taking over now, right? So the daughter says, and Mom, with all the trouble you've been having later, maybe it's time to let me handle your finances. What do you think? Turning to you. So it's like, oh, here we go. Right? Now you're going to be brought into this, melee of Mom not wanting to give up her finances. She doesn't want to burden her children, right? Then the daughter comes in and goes, look, I kind of know what's best. You shouldn't be handling them. So she's going to try and do it in a very subtle way by going, see, it's the doctor's fault. It's the nurse's fault, or whoever it might be. So how do we address a question like this? So let's go back. We're going to focus on the patient. I hear what she's saying. But let's go back. So we worked on some goals in the past, one of them being your financial goals. You review the goals of wanting to not burden her children, wanting to continue to live in her house, not wanting to go to a nursing home, whatever it might be. But then you do talk about some struggles that she's had. Maybe there has been some recent errors. Maybe there is the benefit of having someone take over, of having someone help. So her financial goal was not to burden her family with nursing home bills. Her relationship goals were not to burden her family. So how do we consolidate these? Oops. Oh, there it is. So there on the bottom left, sorry, that didn't come out quite right. So we could say, do you feel comfortable with your daughter helping you with this? Can you see yourself, is a good way to word things. Can you see yourself allowing this happening? Can you see yourself doing this independently? Can you see yourself managing your finances well for another year? Can you see yourself allowing your daughter to help a little bit? It's a soft way to ask things. Maybe this will alleviate some of your stress so we can focus on other things you enjoy. What are these other goals that she has? It's not only financial goals. You had good relationships through your church. So it's important to know someone's social history. And this is where it's important to keep track of these little things to be able to bring up again, right? Kind of the social interview that we had up front, we kind of lodge in the back of our mind, maybe take important notes, and talk about the things that they also find important. These are their strengths. I do miss them. I don't get out like I did before, focusing on specifically just relationships and leisures. What are some ways that you can stay in touch with them? And the conversation can transition talking about rides and going to church. So again, what are they capable of? Can you see yourself kind of guiding to different outcomes? And here we are at the Caregivers Conference. I would be terribly remiss if we weren't talking about caregivers, as we all are in the healthcare field, and also as they have just down the hall here. This is my third conference. It's always lovely to see just the number of people that I think feel that they're suffering in isolation because they're not able to get out like they had once before, and to see everybody come together really means a lot. So it's important to keep in mind the caregiver. Sometimes they are more open than others. In this case, she comes to you just as you're putting on your coat and says, I feel I am doing much better, but I don't know what more I should be doing. Right? What does this sound like? Right? Like, I don't know what more I should be doing. Right? She's feeling really guilty. She's feeling that even as much as she's doing, there needs to be more. So again, this is someone you can provide education. You can tell them, you can give them a list as to what can be helpful, but she's speaking more broadly here. She's really trying to talk about her guilt and her own emotion, processing her own emotions rather than looking for education. So again, this is a case not to be an expert, but to talk with her on her own strengths. So I can see you deeply care for your mother, acknowledging whatever the emotion might be. What do you do to help care for yourself? Right? You care for other people. What do you do to help care for yourself? I always encourage people, these are the things you need to be doing more of. Very rarely, if ever, do I come across a caregiver who's focusing more on themselves than the care recipient, right? So it's important for them to be able to care for themselves. We'll go back to that question there at the bottom left. What has helped you manage stressful situations before in the past? And we come full circle here as to how versatile just these general questions can be. What are her strengths? What are her goals? What does she hope to come from this diagnosis? What does her support system look like? And then we get out our table and start to fill it out again in front of her. So it's important to have a family approach. When Breath Becomes Air is a phenomenal book, if anybody's had a chance to read it. It's about a doctor who was diagnosed with lung cancer when he was in his mid-30s, and he always wanted to be a doctor and an author. And he said, well, I'm kind of running out of time. and wrote a really poignant, powerful piece as to what is important in life. And he talks about it from a doctor's perspective and then also a patient's perspective. And I think no truer is it in dementia is that any major illness transforms a patient's or really family's entire life. So I want to say that quality of life is possible despite dementia. So again, dementia is part of the suffering that we have in this world. But there's importance in finding goals, in finding enjoyment, and what we want to do. So again, you don't want to be goal-oriented during these interviews. I know we all have these sheets of things that we have to fill out, and we feel like we're always running behind. But there are better ways than just running down a checklist to talk with somebody and kind of go back and filling it in afterwards. You want to find their strength while acknowledging their struggle. Again, not to say like, yes, but whatever the but might be, even if it's, but we'll get through this. Again, it's saying it. It's like, yes, that's difficult, and we're going to get through this, and we can do this. We're acknowledging the suffering and the strength. And by doing this, we provide a sense of control. We're going to focus on what remains versus what's lost. This is versatile in any illness. And it's important to remember that family caregivers also need their support and their strength. Any questions? I think there's about 10 minutes left. I did a good job not going over. How difficult is that conversation? All right. How difficult is that conversation? And I think there's a number of different ways it can go. Are you thinking of one example in particular? I know. I mean, a lot of times that can be a way to acknowledge some of the difficulties that they've had in terms of, saying if there's been any accidents or any close calls. Like, that must be really scary. Like, well, what was that like to go through? And sometimes they're like, no, it was fine. The other people were driving into me. But trying to say, well, if your daughter, if your family, are there other easier ways so that way you don't need to worry about those other reckless drivers out on the road? Is there something, can you have your groceries delivered? Which I know is easier in the younger population, I think, because we're more technologically versed to be able to do that. But trying to find other solutions around it that way. I know the Rhode Island Geriatric Education Center has a really nice lecture on kind of having that conversation. I hope it's still on their website. I would refer to that if they do, because it's a whole lecture within and of itself. But I hope that's helpful in terms of kind of acknowledging maybe some of the struggles they have to try and come up with some solutions for it. Mm-hmm. Yeah, no, absolutely. And I think that's where it can be very difficult, is if you do have a person who has no insight into their cognitive decline or their poor memory, and they can still think that they live back on their own. It can be very difficult, because at that point you're not able to really have that therapeutic relationship. So kind of towards the end stages of dementia, I would say it's not as useful, but it's helpful in terms of speaking with the family to see what their goals of care are, at that point. Because they'll probably need long-term care at a certain point if they're really not having any insight and, not doing, if they're being unsafe in the community, that's kind of a qualification for long-term care sooner than if they're accepting of help.
I just want to say I'm very familiar with Clifton Strength Finders in the corporate world and executive leadership.
Mm-hmm.
And it is wonderful to see the application in healthcare and working one-on-one with clients.
I think it was the 34 business strengths, right?
Yeah.
So it can take even just something that's like aggressiveness, which can be, not necessarily a good thing. That can have a negative spin, but that can be good. That if a person is really, forthgoing, might be a better way to say it. So I think there's always strengths within even things that could be more negatively spun. So I know it was nice to read just the number of applications that this has. You had a question?
I was thinking of applying it in a situation where I come from a home care situation, and the family has been helping out, and now they are desperate. They have to get back to work and pay their bills, and they call you at the last minute. So now it's like a crisis intervention, and I would also like the application here and the language, because it's always
Yeah.
about words.
I think so. But I know what you're saying, I think, in terms of, right. Especially if they have distrust towards healthcare, right? Like, I think that's something we don't always talk about, is that people don't necessarily want to go to the doctors. Some people have never seen doctors. Nursing is a very well-trusted profession, but just in general, they might be like, what do they know, kind of a thing. That can make it difficult.
I think that healthcare itself has become such a massive confusion for everybody, because that's quite honestly.
Where do we begin on that? How much time do I have? I know. No, I agree. I think a lot of different professions sometimes are trying to do a lot of good things, but not always necessarily together. And then that lack of communication between people, between the different arms of healthcare, has really led to a lot of problems and can lead to just kind of distrust in general. This is where I think it's important to recognize a person as the individual that they are, and I think people can tell, right? Like, if you're being genuine and really asking about them and not just going through this list of questions because it's a part of my job as opposed to like my occupation. This is my profession, right? Like, nursing is my profession. This is what I've chosen to do. It's not really my job. My job is that I work at the Westerly Hospital. So if you're genuine and honest about that, I think people will give you a little bit more than if you're just going through this checklist that we have, all this paperwork that we have. They just see it as then a job. Any other questions? It's been a pleasure to come up and speak today. I always enjoy coming to this conference. It's nice to see everybody again, and hopefully I might see you out there. Thank you so much.